Well, welcome. We hope you're all having a wonderful start to fall. My name is Jessica Keating-Floyd, and I direct the Notre Dame Office of Life and Human Dignity in the McGrath Institute for Church Life. And my co-host is Carter Sneed. Carter, do you want to introduce yourself?
Hi, yes, I will introduce myself. Thank you, Jess. I'm Carter Sneed. I'm the professor of law and concurrent professor of political science here at Notre Dame, and I'm also the director of the DeNicola Center for Ethics and Culture.
So the DeNicola Center and the McGrath Institute have teamed up to bring you a series of panels to discuss the wide-ranging impact of DOBS for medical care providers, for policymakers, and of course, most importantly, for the well-being of women and children. If you missed our first panel, you can view the recording on either YouTube page of the McGrath Institute or the Center for Ethics and Culture. And it's our pleasure now to introduce our panelists.
We are delighted to be joined by Mary Bauer, who is a certified nurse midwife and director of midwifery services at Ascension Health St. Mary of Nazareth Hospital in Chicago. Welcome, Mary.
Thank you.
We're also joined by Charlie Camosi, professor of medical humanities at the Creighton University School of Medicine. Welcome, Charlie. And Dr. Karen Dehan, associate professor of obstetrics and gynecology at Loyola University Health System and chairman of the Department of Obstetrics and Gynecology at Gottlieb Memorial Hospital.
And finally, we're joined by Joseph Piccioni, ministry ethicist for the OSF healthcare system in Peoria, Illinois. Welcome to all of our panelists.
Without further ado, let's begin.
So those of you who joined us last time will recall that we were discussing, or our conversation focused on questions, difficult questions that really focused on the clinical context involving the delivery of healthcare to women and babies. Difficult, hard cases, if you will. We had a great conversation with eminent practitioners that shed a great deal of light on a lot of questions that have been bedeviling the public conversation in that regard. Today, we're going to shift our focus a little bit more to the practitioner, away from the patient and more to the practitioner, to talk about how in a post-Dobbs world, the practice of medicine has changed, and what the opportunities are and the challenges are and the imperatives are to care for moms and babies and families in a comprehensive way. We're going to start our conversation today with an assessment of the current landscape for all of these healthcare providers. We're going to focus specifically on a couple of very influential professional societies. The American College of Obstetricians and Gynecologists and the American Board of Obstetricians and Gynecologists have been, at least at their executive level and their official statements, outspoken proponents of abortion, even going so far as to call it a standard of care in certain circumstances, which have significant consequences in the malpractice context and on professional disciplinary matters. We'd like to start with the question, we'd like to direct this question to Dr. Dehan. How is the position of these professional societies, as influential as they are, how have they affected the medical profession vis-a-vis abortion? What challenges face doctors who are opposed to abortion as a matter of conscience, or who believe that abortion is not, in fact, acting in the best interests of their patients as they understand it in light of their training and the goals of medicine itself? Dr. Dehan.
Yeah, thank you. I think it really, ACOG and ABOG have really changed the narrative, specifically of my specialty, obstetrics and gynecology, since I finished residency back in 1990. When I chose OBGYN as a specialty, I and everyone else that I worked with, chose this specialty because, our goal is we wanted to deliver healthy moms and healthy babies. We wanted to diagnose, treat, manage, gynecologic cancers. Abortion really wasn't a reason that any of us chose obstetrics and gynecology. It really wasn't, talked about. We knew it was there. It wasn't done at any place that I'd ever worked at. No one had expressed any desire to want to be involved in abortion. And, over the years with the American College and the American Board taking such a strong pro-abortion stance, the whole nature of the specialty has changed over the years. And because of that, it's changed medical education in terms of the medical students and the residents that I work with. And, sadly, because of their stance, a lot of medical students and residents don't, or the medical students don't think that they can choose OBGYN as a specialty. I have had, dozens of medical students come and talk to me and say, I'm really interested in obstetrics and gynecology, but the current nature of the specialty scares me. I don't know if I can do it. And that is, really disappointing to me because, there's a lot of very qualified physicians in training that might otherwise choose obstetrics and gynecology. And because of this strong stance of ACOG and ABOG, they don't feel comfortable that this is a milieu that they can practice in. And I have had my own thoughts as I try to guide the medical students and say, yes, you can do that. We need you. We need you in this specialty. You can do this. I look back and I think it's so strident these days. I'm not entirely sure that I would pick it again, which is very disappointing. So I think with medical education, a residency is probably one of the greatest impact. And then when you look at, so what does that mean? And for those, who it's against their conscience. I think one thing is when you get out of residency, I think it's going to be harder to get a job because that started to be somewhat of a litmus test for practicing obstetrics and gynecology, that you are, a proponent of, so-called reproductive health or reproductive justice. So I think there's a lot of sort of negative things that ABOG and ACOG have sort of created.
It's interesting because it's in some ways a paradox, because ACOG speaks as though they speak for the entire organization, all the members. But recent social science studies, in fact, surveys of the junior and regular fellows of ACOG showed that only 23% of them perform abortions at all. And then they were asked, and then only 7% of OBGYNs in private practice perform abortions. And then when they were asked a follow-up question in the study, I think Guttmacher was involved in the study, they asked them, why wouldn't these folks prescribe pills for abortion? So they focused on the question of medication or chemical abortion. And over a third of them said because they had moral objections to it, which is quite striking, because you would imagine, as you just said, especially people going into medicine, thinking that they shouldn't go into OBGYN as a specialty, when in fact, the vast majority of OBGYNs do not perform abortions, and many, a significant percentage, clearly choose not to because they don't regard it as ethical or consistent with what they believe is the best interest of the patient, mother, or certainly baby. Let's give the other panelists a chance, if they wish, they don't have to respond to this same question. Let's go, Nurse Bauer, please.
Hi, I'd like to also bring nurses and nurse midwives into this conversation because I need to call attention to the fact that the American College of Nurse Midwives is also radically pro-abortion. And there is a subset caucus within the American College of Nurse Midwives called Pro-Life Midwife Caucus. I had been a member of that caucus for a number of years. And it seems that it's counterintuitive that midwives would even be pro-abortion when our whole field kind of got its foundation in birthing babies. So it's changed drastically in my own career as well. I felt very comfortable becoming a midwife. Today, the American College of Nurse Midwives has become so radical, even at the conventions, the annual meetings that we have, that they have abortion training classes that are available. At the last meeting that I was at, we had a meeting of the Pro-Life Midwife Caucus. We're always relegated to a 6:30 or 7 a.m. meeting in a meeting room in the basement of whatever hotel we're at. And I was speaking at that conference on my experience with the abortion pill reversal protocol. And they actually planted pro-abortion midwives in that audience to heckle me and to disrupt my train of thought as I was speaking there. And for an organization that claims to embrace diversity, they don't embrace diversity of opinion on this particular topic.
Thank you for that. That's an important perspective. And for another one of our panelists who has done a great deal of work on the question of nursing and the ethics of nursing, Dr. Charlie Camosi. What are your thoughts, if any, on this question about the role of these professional societies creating an atmosphere that seems to want to crowd out any other alternative voices on the life issue?
Well, there's obviously lots of reasons to be pessimistic and sad about this, but I just want to highlight a story that many of us are aware of, but I think is worth focusing on, that give us reason for hope. Many of you know Dr. Kristen Collier at the University of Michigan Medical School, friend of both of the societies that are supporting this event today. And what has been astonishing, at least to me, about her very publicly giving the white coat ceremony, plenary address, and being walked out on by several students and faculty members and others, although not as many as you might think. What's been astonishing is the level of support she's gotten, even from pro-choice students. So there is a lot of reason to be hopeful that if we stand up, if the right people stand up, if they get the right support about this, that there can be changes made. There can be stands made that are helpful. Let me just finish by saying this. I think if we get a pipeline going of even all the way back to middle school, I'm doing some lectures for Lumen Verum Academy online, a new school, Catholic school out of the Archdiocese of Boston. And there are future healthcare providers in the classes that I'm lecturing to virtually there. And if one of the things that Kristen did so well at the University of Michigan is mentor also pro-life students that need advice about various things, including applying for residencies and whatnot. If we can get a pipeline together, I think this would really be helpful in kind of turning the tide to make sure those students are supported all the way through.
And finally, Joseph, would you like to add anything to this line of conversation?
Thank you so much. Just from our experience in medical education, decades ago, I was asked by a medical student who was pro-life and strongly Catholic if I could help her find a residency program in OBGYN that would protect her not only from abortion, but doing tubal ligations. And so I was able to craft a protected place for her in our residency program that is sponsored by the University of Illinois. There's the College of Medicine in Peoria. So we have created spaces for persons and for students and residents in general. But with the heightened level post-Dobbs and pre-election of abortion conversation, many medical students who are pro-life are giving each other the message, maybe we should just be quiet for now. Mm-hmm. And so that really doesn't create the type of open academic atmosphere that we would wish, but they're doing it to protect themselves.
I see. Thank you for that. Jess?
Thank you to all of our panelists. I want to shift us to a case that's come up repeatedly since the Dobbs decision, both by the medical professional organizations we've just been talking about, but also by doctors who have said that the lack of access to abortion means that they can't treat their patients. And that case is the 2012 case of Savita Halapanavar, a pregnant woman in Ireland who tragically died of infection and septic shock because her doctors failed to provide her proper miscarriage treatment. And these doctors cited the prohibition of abortion in Ireland at the time. And as we all know, this case was used to overturn or amend Ireland's constitution on fetal rights. So this case has been cited quite a bit in the weeks and months since the Dobbs decision. And so I'd like us to think about what role hospital ethics committees can play in reconciling these ethical conflicts tied to legal conflicts, and how should ethicists be advising doctors on what the standard of care is in a post-Roe world? Dr. Piccione, I'd like to start with you.
Thank you very much. And I work within Catholic healthcare, and in OSF we have a robust staff of clinical ethicists who are scattered across the system so that we can be of advice to people on the ground. Might I also say that within Catholic healthcare, we have a national document that's promulgated by USCCB called the Ethical and Religious Directives for Catholic Healthcare Services. and it's in its 6th edition. The bishops in their November meeting might amend it a bit. And also it's a bestseller for USCCB. ERD, in a way, carries the wisdom tradition of the church into succinct statements. There is a risk that persons can over or under interpret ERD, but ERD 45 is one of those directives in which every single word counts. And it speaks of abortion as the directly intended termination of pregnancy. And it continues. And then the next sentence, every procedure whose sole immediate effect is the termination of pregnancy before viability is an abortion. And so when we heard of the Halappanavar case, we were very saddened because we believe that in the States, we would have implemented ERD 45, but also the following directives, which are more general in tone to reflect our wisdom tradition of recognizing that, yes, we have 2 patients, mother and baby, but sometimes we can only save one. And we followed the Halappanavar case closely. It was tragic, but there were admissions by the Irish hospital that they were not a Catholic facility, that they were not under Catholic ethos. And it turned out that it was really a liability case. It was poor screening for her advanced condition, a not timely response to her, and that there was a several $100,000 euro settlement between her family and the hospital. Yes, of course, that case was used to advance the overturning of the Irish constitutional provision banning abortion. But from a Catholic healthcare perspective, we would not have seen that as an abortion.
Dr. Camossi, you've done quite a lot of work on this case, and you are currently teaching bioethics at a Catholic hospital or Catholic medical school. I'd love to hear sort of your thoughts on both the case itself, but also the role, how hospital ethics committees can be more proactive in informing doctors about ethical decision-making.
Yeah, the case was incredibly frustrating for reasons that I think many of us are frustrated right now. Our opposition and the Irish pro-life opposition, the pro-choice opposition, they really were dishonest, frankly, in how they narrated the case with the intended goal in mind. It was to overturn prenatal justice as articulated in the Irish Constitution, and they won. And I can see, unfortunately, maybe the sprouts of something similar happening here in the United States. There's a lot of disinformation, a lot of disingenuous arguments made about these matters. But part of the problem is, and it's a wicked problem for us, is that especially in the Catholic tradition, we do have a kind of prudential judgment type situation where we look at each individual case and what's the object of the act and what's merely foreseen and not intended. And one of the things I think we need to do, particularly now, is get some very, very clear guidelines in place. Maybe even have a new ERD directed at situations where we are talking about saving the life of the mother in these situations, because we can be in good faith here, and we all are in good faith here, but our opponents are largely not. And so I think we need to really hit the culture, hit ethics committees, hit institutions over the head with what we do and what we don't do, but still making space, as our tradition does, for those hard cases where we have to do prudential judgment.
I'd like to invite Dr. Deehan and Nurse Bauer into the conversation as a sort of practicing in the field, how you think about ethical directives in your decision-making. Feel free to reflect on the Halappanavar case as well, but to bring in that practical on-the-ground application of decision-making in sometimes challenging cases.
Well, I'll go ahead if it's okay, Mary. Sadly, this is a situation that we face, as practicing, obstetricians, we face not infrequently this very tragic situation of premature rupture of membranes pre-viable. And I have not changed, and no one that I've worked with has changed their practice over the years in managing this tragic complication, and it's monitoring. And we all know how to monitor for chorioamnionitis. We all know the signs of infection. And I think what's been done in that case is an indicated induction of labor that's necessary to save the mother's life has been termed an abortion, and that's not correct, as Dr. Piccioni referenced to the ERDs. But I think that that's sort of the crux of the case, and they're used, and this is being used as a situation that's being termed more in a negative aspect, where it is, again, the situation of, as Dr. Piccioni said, two patients, and we do the best we can for both patients, and sometimes we're not able to save both patients. But this is a situation that we see very frequently.
Thank you, Dr. Dehan. Nurse Bauer? No.
We'll also see cases where there's an ectopic pregnancy, and the moms are very upset about this because they don't always understand where the location of that pregnancy is, and that it is not viable no matter what we can do for them. And we have some patients that are in the Latino population, very faith-filled, consider this possibly an abortion. We have a great obligation to teach them exactly what is happening in their bodies, and that, as I work also in a Catholic hospital, we do not consider that an abortion. That baby will never be viable in its location outside the uterus. And the risks to the mother can be very great if we don't intervene.
I want to thank you all for responding to that. And Charlie, pick up on your point and Dr. Piccioni's point, as well as Dr. Dehan and Nurse Bauer, that doctors know what the protocols are and how to treat their patients, but that we have maybe like a public facing challenge of really making clear on ethics boards and to OBGYNs practicing potentially in non-Catholic hospitals what the ethical guidelines are for treatment of patients. Thank you so much. I want to pitch it back to Carter.
So our next couple of questions are going to be about the use of drugs to induce abortions. We've already seen RU-486 and abortion drugs have mifepristone, misoprostol have kind of revolutionized the performance of abortions. It's a huge and growing percentage of abortions that are induced in this way, and you see in other countries the rates of chemical or drug abortions are significantly higher than surgical abortions. Counterintuitively, the evidence seems to suggest that complications and difficulties for the mother are actually more significant in the context of the drug-induced abortion than the surgical abortion. That is in some ways counterintuitive, at least if I'm understanding the social science correctly. So we'd like to ask our panelists just a general question. We're going to get more specific in the next question. Just how do you see the prescription of abortion-inducing drugs, and especially we're going to be seeing now with those jurisdictions like Indiana that restrict access to surgical abortion and ban the use of abortion-inducing drugs, the use the sort of distribution across state lines into our state. They're going to flood. They're already talking about flooding our state with these drugs. They're encouraging women to stock up on these drugs in advance of a future need to get an abortion in states like Indiana, even though the use of those drugs is illegal. Although the mothers are immunized, anybody who has accomplice liability around that would presumably be prosecutable. So our general question, what does it mean for the drugs and the mailing of drugs and the use of telemedicine and perhaps even unsupervised use of these drugs? How do you see that changing the practice of medicine and the safety of mothers and, of course, of babies? Mary, if it's okay, why don't we start with you? Nurse Bauer, why don't we start with you, and then we'll go around the group as well.
Well, when patients can obtain these drugs basically unfettered, they really don't have any opportunity to discuss any concerns regarding taking them, side effects, contraindications for taking them with a provider that may be completely knowledgeable. A lot of pro-abortion advocacy groups are now putting websites up online where you can call and talk to a person, not necessarily a nurse midwife or an advanced practice nurse or a physician, and they may ask them a couple cursory questions, and in overnight mail, they're receiving abortion pills to be taken in the privacy of their own home without any supervision. And that can be extremely dangerous for patients.
Mary, could you give us a few more sentences on what the precise dangers and complications are, especially as you've seen them in your practice?
The biggest risk, I think, to moms would be hemorrhage and bleeding. Dr. Dehan may agree with me on that if they're taking them at home. And, you know, a mom could bleed out at home if she has nobody there. She might be taking these pills in total privacy. She may not want her sister, her mother, her best friend, or anybody to know that she is doing this. And she could be found dead on the bathroom floor. I mean, that is a reality. Although the risk of hemorrhaging is considered to be low, sometimes there are also organizations that are kind of pushing the envelope on the restricted guideline as far as 70 days to provide abortion pills. They may kind of push the envelope to say, well, she's 11 and a half weeks, we can try giving them to a patient. And your risk of hemorrhage goes up, I think, considerably more after 10 weeks. And that, I think, is probably the biggest risk. But not, you know, knowing a woman's health and not being able to give good guidance really puts her at a lot of risk. And socially as well, not just the risk of the medication, but not having the support that she needs to make the right decision.
Dr. Dehan, we'd love to hear your thoughts on this, and especially as a physician. I mean, as a doctor, thinking about what the practice of medicine is and how to do so ethically and at the highest degree of professional excellence and care for your patients, to act in the good of your patients as you've been trained to as a physician at the core of the art of medicine directs you to. How does this sort of shift, this growing shift in the direction of the dispensing of abortifacient drugs, telemedicine, and even, as we just heard from Mary, unsupervised use of these drugs? What's your reaction to that?
Yeah, the abortion pill to me is particularly frightening, and you know, for some of the reasons that you just said. And women are taking the abortion pill without proper supervision or without proper examination beforehand to know things like how far along in the pregnancy are they? Do they have any bleeding diathesis or contraindications to taking the medicine? Do they possibly have an ectopic pregnancy where that would be catastrophic? She could have a ruptured ectopic if she thought she had an intrauterine pregnancy that she was going to abort and took the abortion pill and ended up having a ruptured ectopic. As Mary said too, it's really hard to counsel someone, I think, on how much bleeding is appropriate. You're going to take these pills and you're going to have this amount of bleeding, and you know, it's a lot of bleeding, and should you stay home? Should you go to the emergency room? We see patients every week in the emergency room who come in after having taken the abortion pill that are either bleeding heavily or worried about bleeding heavily, and follow up. And then they're in the emergency room. Most of the time they have no relationship with any practitioner. They are sort of on their own. They show up and they haven't formed a relationship with anyone to help them, you know, not only with the medical complications, but then the sort of emotional and psychological complications of having gone through this, maybe at home by themselves, ending up bleeding, ending up in the emergency room, and sort of, to me, the narrative is very much, oh, it's so easy. You take the abortion pill, you stay home for a couple hours, it's all done. The next day you go about your business. And that's another huge disservice I see, that this is being promoted as such an easy, complication-free thing to do. And that is just not the case. Yeah.
Can I just one follow-up question? How is it possible for a person to seek a prescription or to seek access to abortion drugs from people outside of your state, maybe even outside of your country? How does that work? I mean, how does that work?
I have to be honest and say I don't know exactly. I mean, I think it may differ state to state and what one can do. I know there's availability of many prescription drugs from some Canadian pharmacies and other things, but I don't honestly know how that's obtained.
Mm-hmm.
Well, there's several organizations that will provide them via the internet. A couple of them that I looked into, one's called CareFM. There's another one called HeyJane.com. And they will, some of them do a video consult ahead of time and others don't. And they charge anywhere from $280 to $400 for these pills, but they don't offer an ultrasound, as Dr. Dehan said, to verify the number of weeks they're pregnant and so forth. But they're out there, and these pro-abortion advocacy groups are becoming more and more and more vocal on the internet. They really are.
Yeah, no, we see that even on our campus. We see advertisements with QR codes in bathrooms,
right.
Where students are with the most extraordinary, dishonest and deeply disturbing language. Want to become unpregnant? It asks the question. Wow. Take Plan C. These are deeply, deeply dangerous, unethical, and problematic streams of information that are being circulated, I'm sure, all over the country in those places where they imagine people are going to not have access to surgical abortion, in those jurisdictions where the legislatures decided that they want to protect mothers, babies, and families through the mechanisms of the law and forbid the use of these drugs. It's heartbreaking. Dr. Camosy, we'd love to your input on this question about the proliferation, the shift to prescriptions of drugs and the use of drugs in this way.
Yeah, we're not ready for this, it seems to me, and we're learning fast, and we're making some moves. I guess one thing I wanted to mention is the pro-life movement has for decades now thought about what it would mean to have prenatal justice and ban most, if not all, abortions and still have illegal abortions done. And we've been thinking about that in a surgical abortion context, I think, for the most part. But obviously what presents in front of us now is the prospect of illegal abortions being done this way in a much more systematic and nefarious way. And I think it underscores, nobody's a stronger proponent of prenatal justice than I am in wanting prenatal children protected in law, just like any other person. But I think it really does underscore the importance of winning the culture. We have to win the culture, and changing the law is part of that. Recognizing prenatal justice is part of that. But this new threat, I think, just underscores how much the winning the culture question is before us.
That's a really important point, and it is frustrating because it's hard to break through sometimes with the message of solidarity and unconditional love and care and a genuine understanding of what the good of medicine is as a field of healing and wholeness, rather than simply a problem-solving intervention. But it's hard, Charlie, as you had said earlier, when the sort of public discourse is flooded with misinformation and flooded with some genuine confusion by well-meaning people who are terrified, and we have to obviously be sympathetic and compassionate about that. But then there's some other people also who are, I think, trying to create ambiguities and even misinformation for the sake of promoting a particular ideological agenda, and that's not okay to do. And Charlie, you've been a great proponent and sort of antidote to this with your own writing, as has everyone else on this panel with your personal witness, and we're just grateful for that. Dr. Piccioni, we'd like to get your thoughts, please, on the question of the proliferation of abortion drugs and how that affects the practice of medicine, delivery of healthcare.
Yes, we believe that 50% of abortions now are chemical rather than surgical. We don't know exactly which individual practitioners might be in that direction. Certainly in Illinois, every Planned Parenthood clinic now offers chemical abortions. So it's It's much more vocal in the past, and it's becoming much more present, yes, and we see the risks for it. Although, Professor Sneed, could I continue with the thought that you had about conversation in general? I think that Catholic healthcare is at the intersection of medicine and our faith tradition of the healing community, and we recognize that our mission partners in Catholic healthcare and external physicians, we are all motivated by humanitarian instincts. We struggle, though, now more than ever with overlapping definitions of what abortion might be or what might good medical interventions would be, such as in the Irish case. And we have to be more intentional than ever in creating some kind of common forum, because it's not happening in public right now, but internally, so that we can work on certain terminology. And it is a risky time for discourse. And as you said earlier, we are motivated by love. ERD for Catholic healthcare says that the animating principle, and that's the strongest theological line for me in ERD, the animating principle of Catholic healthcare is the love of Christ. Yeah.
That's very beautifully said, Doctor. Thank you for that. And I agree. If I could ask you a follow-up question, I agree with you. As a law professor and as a legal scholar, the question of language and nomenclature and defining with particularity what an abortion is versus what is merely an intervention that has the foreseeable but regrettable consequence of leading to the death of the unborn child, for example, premature delivery of a child following, if the membrane ruptures, you're delivering a pre-viable child and doing everything you can to care for that child, but it's just not possible to save his or her life. The law has to be very specific in what it defines as abortions. And there are some good examples of that. We saw that in our previous webinar, where we talked about how we looked at some model language from different state statutes that defined abortion very specifically with respect to the intention of the act itself, and which distinguishes it, and for that matter, the factual circumstances around it. So a miscarriage, removal of the remains of an unborn child is not an abortion in the statutory language, because it's not an action with the intention of bringing about the death of the innocent child. And intention is a tricky thing. I mean, it means different things in moral theology than it does in law. Foreseeability is treated differently, especially in malpractice law and the law of negligence. But if I could just ask you a follow-up, Dr. Piccioni, what would be your advice in terms of how we might be more precise internally in the Catholic community, using which words to describe the nature of these actions and how we can bring light rather than more confusion? What would you, if you were writing on a blank slate, what might you add?
Certainly, I think that again, ethical and religious directives gives us some very good language. It's widely circulated. It is normative for Catholic healthcare. ERD, the bishops say, is policy in every Catholic institution. And so it gives us some good definitions. So with the premature rupture cases, that would be ERD 47. And it begins by saying, if it's not, the intention is not abortifacient, it may be pursued. So we do have our own internal language. Those who are advocating for abortion, again, we saw this clearly in the Irish case, are trying to say abortion was the only option. The medical review of the Helipenar case said that delivery should have been expedited, which in another way is saying induced labor or early delivery. That would be the language we would use in the Catholic tradition. And certainly for almost the last century, one of the rationales for that would be for an opportunity for baptism while the baby was still alive. So we are accustomed to tragic events. With advances in medical technology, we can save both mother and child better. And medical practitioners strive, even when we have some membrane ruptures, to be able to continue the pregnancy to a viable date. The Irish case was 17 weeks. And if it was, the type of rupture and the sepsis that followed, and there was perhaps even a suggestion that it would have been an antibiotic resistant infection, well, then we face the reality of the pregnancy has essentially failed. Abortion is not the answer. The pregnancy has failed. How do we induce labor? So it's always language and clarification, because even within our Catholic healthcare community, we'll have colleagues who really need the assurance that what we're doing is morally sound. And so we have to be a community of communication. And so I would advocate for Catholic healthcare to invest in ethicists who can promote that type of conversation and to further it.
If you don't mind, Dr. Piccione, I'd like to ask you one follow-up question really quickly. I have read some literature put out by some Catholic bioethics institutes that really would say early delivery is abortion. And that seems to me problematic on several levels. But how, even internally, sort of in Catholic hospitals, how do we sort of assure that everybody is on the same page and reading from the same playbook to protect moms and babies?
Yeah, thank you. When we look at the history of Catholic theology, we have many different schools of thought, and so we don't have always a history of agreement. Mm-hmm. We have a history of disagreement, sometimes putting new perspectives to it. But from the position of hierarchical teaching, I think that it would be out of step with the mainstream of Catholic thought to consider saving the life of the mother when the pregnancy has clearly failed as abortifacient. Again, this is where overlapping definitions come in, because in a medical definition, one might say for abortion that it is that the pregnancy simply failed. In the same way that in airline travel, we would abort a takeoff or abort a landing. Theologically, that's where intention comes in. So my response to an individual who would make the claim that it's always and everywhere an abortion would be, let's look at the facts of a specific case. Can an individual practitioner make a wrong judgment or a hurried judgment that the pregnancy has in fact failed? Or by my conversations with physicians over the years, they know our moral framework, and we share a vision that our patients are mother and child each, and that we will advocate for both.
Thank
Again,
you so much.
This continued conversation is important.
Thank you so much. I want to take a moment to talk about abortion pill reversal, since we're talking about chemical abortion. And Mary, particularly since you brought up your experience of being heckled, talking about it, can you tell us about abortion pill reversal, how it works, and also how we can more effectively get the message out about abortion pill reversal?
The abortion pill reversal protocol is basically larger doses of progesterone, which is a hormone that your body makes to sustain a pregnancy. And when a woman goes to have a medication abortion, there are two drugs involved. The mifepristone is the first medication, and then we give her misoprostol on the second day to expel the contents of the uterus. The mifepristone lines the uterus, and when we give the progesterone to a mom in a large amount, it competes with the mifepristone sites on the uterine lining. So it kind of can knock them off and help sustain the pregnancy. Unfortunately, the study that has been the backbone of this protocol was small in nature, and it was published in 2018. And the number of cases that were involved was small enough that the American College of Nurse Midwives, American College of OBGYNs, everybody is saying not enough information. You really shouldn't be doing anything with progesterone without larger studies. But the protocol, I'll go. We can talk a little bit more about that in a minute. But the protocol itself is to try to intercede after a woman has only taken day one of her abortion pills. if she's taken the second, we really can't help her. So there's a small number of women that will decide after taking the first pills, for what a number of reasons, that they made a mistake and they regret it and they are desperate to try to reverse it and save this pregnancy. And we try to start them on progesterone within the protocol of 72 hours. Ideally, the first 24 hours would be more effective, hopefully, but it only works to a certain point in pregnancy. So you can't be giving it, after the 10 weeks. I mean, that the abortion pills are given up to 10 weeks. So sometimes we'll get a patient who's only 6 weeks pregnant. And it seems from the anecdotal part of that study, the earlier that we can intervene with the abortion pill reversal protocol of the progesterone, the greater likelihood of success. And there's a lot of pushback from our professional organizations not to use it. I feel that we have an ethical duty to our patients to offer this, especially in a Catholic healthcare setting, because it involves basically two ethical principles. One of them is non-maleficence. So basically, don't harm your patient. We have, a practical application to weigh the benefits versus the risks and choose the best course of action with our patient. The second principle that's involved in this really is beneficence. It's our moral obligation to act for the benefit of our patients, to do the right thing and to look toward the patient's good. And when a patient is coming to us, asking us for help to save the life of their child, their human child, it's hard to harden your heart and say, well, it's a small amount of evidence, so I'm not sure we should use it. Prayerfully, I have used it for a number of patients. I was part of the organization that was prescribing it. I've had some amazing success stories to share, and including a set of twins. And I've had patients that, after I prescribed it, went home and decided it wasn't for them. They were going to go ahead with an abortion, often due to pressure from boyfriends or family members as well. But a lot of the hospital systems are concerned about the risks, for lawsuits involved, because there is very little knowledge about the use of progesterone. This is kind of an off-label use, if you will, but yet we give it to pregnant women to help them sustain threatened miscarriages. Dr. Dehan, you may even be able to add to that.
Mary, I think you summed that up really well. I don't have a lot to add, but I would reiterate that in terms of my colleagues and those in the American College, that we faced the same response, that there's not any evidence, the studies are small, the numbers are small, we don't have that. And on the other hand, you don't see any of them running out to try to do the studies to see if that's something that, they have no interest in,
Right.
in putting any effort or finances to doing those studies. And it's not something that I think with limited resources, it's easy to get huge numbers on this. This is a fairly rare at this stage in its, as it's sort of its nascency. It's a fairly rare thing. I agree. I think it's the times that we've discussed it, we don't do it at our institution. It's been discussed here and there, but the response is always, oh, that's not really standard of care. I think we use a lot of medications that are off-label, and we do that not infrequently, that people don't have a problem with. But this has been a much harder sell. I applaud you for doing that. I think that should be an option for women.
Well, I will add that my institution asked me to stop doing it because of their risk of malpractice. And I am hoping at some point that maybe we can take this more to the Council of Bishops and maybe come out with a statement saying that this is something that is for the greater good of women and it's worth doing. I'm not sure how to make that happen, but I do think it's something that we do need to look at. And I'm saddened in the fact that I am not able to provide that care for women. I have a couple of resources where I can send patients now for the abortion pill reversal protocol. But I will tell you, I will never forget the morning at 6:30 a.m. and I was in my car out to buy donuts for my family when I received a phone call from the abortion pill reversal organization asking me to take a phone call from a desperate mother. And when they connected me with her, and she is desperately sobbing on the phone, begging me to help her. How can anyone say no? And ultimately, she did give birth to her son. And it made it worthwhile for me to be able to take that step. I don't consider it a risky step. I consider it that we may not have full knowledge of the use of this, but as Dr. Dehan said, we use a lot of off-label medications caring for our patients. If we use that as a disclosure saying, the evidence is small, but it might be worth trying, we do that all the time in medicine. I don't see why we shouldn't be doing it for these ladies.
Thanks, Mary. Carter?
We have time for one very sort of lightning round, short answer, one or two sentences, and then we'll have to close out this wonderful discussion. So the University of Notre Dame is institutionally committed to promoting a culture of life, and organizations and institutions within Notre Dame, like the McGrath Institute and the DeNicola Center for Ethics and Culture and countless other faculty and students and staff, are devoted to building a culture of life and a civilization of love in a post-Dobbs world, a landscape in which moms and babies and families are cared for the right way. You all are on the front lines of this struggle to care for moms and babies and families. What is one thing that we should keep in mind that we should do to work towards this goal together in a loving way that extends unconditional love and care and solidarity to all? Let's start with Dr. Camosi, and then we'll go through one or two sentences.
One of the things that the abortion pill reversal discussion reveals, and is uncomfortable for our opponents on this, is just how many women are being pushed to have abortions they don't want to have. And often they're women of color, often they're economically vulnerable women, and often it's men who threaten intimate partner violence as part of the process of coercing them into having abortions they don't want to have. What I think we ought to focus on, in addition to many other things that are available to us, is providing housing, especially for women who are threatened by intimate partner violence. It's one of the most, unfortunately, expensive interventions we can make, but especially in light of how often abortion correlates with intimate partner violence, and especially women that have multiple abortions, we need to get housing for these women. We need to get them out of the violent situations in which they find themselves.
That's great. Thank you so much, Charlie. Dr. Piccioni.
Thomas B. Merton said that action flows from contemplation. As a moral theologian and as an attorney, but primarily as a moral theologian, I believe increasingly that the Catholic worldview, or imaginary, really begins with that experience of God and spirituality. So to connect everything together and to pray the simple prayer, apparently it was Father Hesburgh's favorite prayer that he would repeat during the day, "Come, Holy Spirit," that we would have the eyes to see not only the individual before us, but as Charlie said, the social dimensions of the reality in which they live. So increasingly, it is seeing the big picture and having confidence in the spirit of life and love to carry us through.
Thank you very much. Dr. Dehan.
Well, I think I can only speak as a practicing obstetrician gynecologist, and I'll kind of call out my colleagues that what we need to do in the exam room with the patients when we're there face to face is help them get the resources that they need to know that they can support their child and support their family. And as an adjunct to that, when I have the medical student in the room with me to help them see that they can join this field, they can be in medicine with these views to help these women understand that choosing life is a a viable option for them.
Finally, Mary.
I would certainly say encourage the use of midwives out in the community, in clinics, especially in underserved areas of the city and rural areas. They tend to provide connections for the community. The roots of midwives came back in the days of, village grannies and people that they trusted. Fortunately, today, it's not just the granny midwife. We're well educated in our field, but patients have the opportunities to create relationships with their midwives, with their family docs, with their obstetricians. When we can really nurture relationships with our patients, they can come to trust us, and we can together help solve their problems.
Wonderful. Jess, why don't you take us out?
Sure. Friends, thank you so much for joining us today for this really rich and layered conversation about how we can move forward to embrace the flourishing of women and children and embrace our practice of medicine moving forward post-Dobbs. We want to thank, in particular, our presenters and also our audience members for joining us today. Christina will drop in the link for the next panel, which will be at the end of October. Please take a moment to sign up for that, and also be on the lookout for the video recording of this webinar early next week. So thanks again for joining us, and have a great afternoon.